their findings on bowel toxicity after prostate radiotherapy. Thank you.
Thank you very much. Can you hear me?
Yes.
Yeah. Okay. Thank you, Julia. That was very helpful. So in the next 15 minutes, I'll show you what you can do with prostate cancer audit data. So we got a list from the audit team with all the patients who had primary prostate radiotherapy in our center over 2 years. And we also got the list of the patients who had toxicity. Now, I think this type of audit is presumably done by a number of centers because we all were curious of were the data correct, you know, how many patients really did have toxicity, was it an over-reporting and under-reporting, and so on and so forth. So we so over the years we have about a 3 to 5% toxicity rate, which is quite low compared to the mean of the UK centers. So on the we excluded some in the non-toxicity group out of those 800 patients, 850 it was actually. We had some missing radiotherapy data because we moved from Pinnacle over to Eclipse, and that deleted the kind of DBH volumes for these. There were some with HDR brachytherapy. There was a patient with postoperative radiotherapy, and one which had previous bowel surgery with a removal of the rectum. In the toxicity group, I know what Alison said. We found that 3 of the patients were actually had a diagnosis for colorectal cancer. So we felt that these shouldn't really be in the toxicity group. And that was a new cancer during the 2 years after they had prostate radiotherapy, so unlikely related to the radiation as such. And then we looked at the whole cohort, and we looked at various characteristics clinically. Then we looked at the treatment volume, what we treated, prostate or prostate and nodes. And finally, we looked at the rectal DVHs and the bowel DVHs. Next one, please. So I thought before I started this, well, maybe the guys from the more deprived areas or the higher comorbidity scores, they will have a higher risk because that's what we normally assume, but nothing of that. They were just the same age group. They had the same deprivation scores, and we have a lot of deprivation in Liverpool and Runcorn areas. They had the same comorbidity index, and the only thing what we found that the higher risk patients and the patients with metastatic disease we treated with prostate radiotherapy had a higher risk compared to the ones with lower risk things, but statistically it wasn't significant. It was just a trend. Next one, please. So what about the symptoms? What did people have? Despite our best efforts, there were 2 patients we couldn't find any symptoms recorded in our records. It doesn't mean they didn't have it, but we just couldn't find it any longer. But it's been a while since they've been treated. And then we had a sort of 50-50 split of bleeding only, and then the bleeding with some functional endpoint, which is diarrhea, proctitis, diarrhea, and pain. Now, these tend to be the patients who have bother, and these tend to be the patients who feel generally unhappy about the way how they are. Whilst the bleeding, unless it's really serious and significant, tends to be tolerated by patients relatively straightforward. There was 1 patient who had metastatic pancreas cancer, which we included in the subsequent DVH analysis. Next one, please. So what about the radiotherapy? Now, we had a protocol, and as I was head of the urology group, I tried to make sure that we all followed the protocol. We have 7 different clinicians, as I want to sleep at night rather than worry about it. So we had sort of clamped down on individual variations. And the way how we done this is if something wasn't complying with the protocol, it needed a peer review by another clinician. And we defined indications, volumes, those organs as risk doses, and so on. So that's a lot of work. And did it actually work? Well, what we found is that patients who had pelvic node radiotherapy had a higher risk, and the risk was somewhere around hazard ratio 3.1, with a significant statistics. So that's in comparison to the prostate only. The palliative patients, this was quite a small cohort and presumably separate from more radical treatments, and hence I'm not going to talk too much about this, other than they had quite large volumes treated, which often relates to very large prostate and tumor volumes. The prostate volume is such because I thought maybe there's a bit of a difference between nodes and prostate. They have slightly larger volumes because they tend to be the higher risk patients. Yes, the prostate only were a bit smaller, partly also because of margin, which we had in the protocol. Next one, please. So what Regio then did is, he's my academic fellow. We went back to the planning system and pulled out all the plans, and we looked at the DVHs for the rectum. So these sort of slightly feathered thin gray lines are the patients without toxicity. And then there is a kind of a mean of that, which is the black thick line. And then there are the patients with toxicity, which is the red line. And that's again the mean over the dose. Because we had two different schedules for the prostates and the prostate and nodes. The prostates we all treated with 1620 or slight variations of that, but with 20 fractions. Whilst the prostate and pelvic nodes in 1617 we still treated with 32 fractions, which was a sort of a Clatterbridge kind of protocol. To avoid that, we had to have patients with 39 fractions because we just simply didn't have the capacity to do that. So you can see that there is a difference between the toxicity groups and the non-toxicity groups in the rectal DVHs. That's true for the whole cohort as such, and if you look separately at the prostate and the pelvic node groups, which was a bit surprising because up till now, these type of differences haven't really been found. Next one, please. So we did a logistic regression with dose bins, and that's the way how Anna Wilkins and Sarah Gallimore did that with the chip data. I'm not trying to reinvent the wheel. We thought we'd just do what they done because that's certainly a fairly valid way of doing it. And as you can see, for all dose bins, even down to 20 gray, up to 70 gray, again, EQD adjusted, the toxicity group had higher volumes treated. Next one, please. Next one, yeah. So in Anna's paper, they have made these kind of plots of risks of doses. So the kind of pink purple boxes are the ones which have a really low risk. Then the blue one is medium, and green, yellow up to red is higher. Clearly you can see there isn't anything with 100%, and I presume the reason is that we used the dose constraints at the time, which were agreed and acknowledged, and I'll show you how they compare to the ones we use nowadays. And you can see in this plot where the pelvic nodes are above and the prostate only is below, that overall the prostate and pelvic node patients had a slightly higher risk, a mean of 8, whilst the prostate only had a lower risk of 2 to 3% of rectal toxicity, significant rectal toxicity. So that was the dosimetric ROC analysis. Next one, please. And you can do that with the bowels too. Now that's been more difficult, and there wasn't such a difference. Part of the problem may be that the actual doses to the bowels are quite low, There is a little bit of dose from the prostate treatments, as you can see in the sort of lighter blue rows. The vast majority of the doses, however, are lower because of the lower dose to the pelvic nodes. In our schedule, it was below 50 gray or 50 gray maximum dose. And so we couldn't really find a dose relationship in with the bowel volumes. Next one. So this is the summary of these ROC analysis Anna has done. You can see that we looked at doses from 20 gray upwards, EQ2 equated, and you can see that we have a kind of done, just like with the trial protocols, we have mandatory and optimal constraints. How you call them doesn't really matter. But these are there to help the planners to get the best possible plan out of a particular plan with a particular bowel, rectal, and prostate anatomy. So in 2015, we still used the old chip constraints, albeit we introduced a lower constraints for 20 gray. And then nowadays we use lower ones, particularly for the higher volumes, in order to reduce the risk for the patients. The logistic regression you can see on the right side. We have used two different methods to evaluate the risks and the volumes. And so there's these two methods called Yoden and CTL indices. The difference of these is better known to the people who understand more about statistics than I do, but just to say that they overlapped fairly nicely and we got very decent AUC values for them. Next one, please. So what's the problem with these analyses we have done so far? The first one is the dose bins. We all know the doses are continuous variables. They are not coming in lumps, like 10, 20, 30 gray and so on. And so we try to find a way to use a continuous dose rather than dose bins. Now, the relationship between a dose and toxicity is not linear. It's not logarithmic either. And there is a sharp increase in the middle and then it flattens out. And the logistic regressions doesn't really help with that because it assumes a linear relationship in the logistic model. The single thresholds are presumably also not particularly relevant for reality because you have an increase in risk which is continuous rather than no or yes. And obviously, because it's biology, then whether it will happen or won't happen, you don't know. But the risk of getting higher toxicity is an increasing risk rather than a yes and a no. We have not been able in the moment yet in that research project accommodate small bowel doses, which I'm pretty sure contribute to bowel toxicity. But how we do this, or how we'll try to do this, I'll show you in the next few slides. Next one, please. So this is something called restricted cubic spline, which is a way of analyzing relationships between dose and volumes, and they are here plotted for different dose levels. The black lines are the actual distribution of the doses and the logarithmic, the log odds of risks. And you can see that the blue line, which is the restricted cubic spline, tracks this relationship better than the purple line, which is the logistic regression. Why is that so? Because toxicity is a complicated biological process. It's not kind of a simple count 1 and 1 together and you get 2. Next one. So we have then developed heat maps, which we basically look at risks depending on dose to an organ risks. So if you look at the very right side, you have a heat map for prostate only treatment. And the green line is a line if you have the doses to the rectum below that line, and I assume now that your contouring is correct, then you will have, as a patient, a very low risk of toxicity, which is somewhere around 1.6% or less. If you're above that red line, then your risk is somewhere a bit above 5%, and then obviously if the doses increase, this will get higher. We have we developed a separate heat map for the nodal patients because the cutoffs for these nodal patients are different. Now we'll talk about this in a minute, but part of the problem with rectal doses is that if you use VMAT planning, you need 2 arcs to treat pelvic nodes, and that invariably increases your rectal doses. At the time when we did the audit for prostate only patients, we used fiducial markers and fairly tight margins around the prostate, 3 and 6 millimeter. For the pelvic node patients, we used cone beam CTs because they weren't particularly good at the time when we did the audit. We had slightly larger margins, and we didn't use fiducials. We didn't just have the capacity to offer fiducials to all patients. So that might have contributed to the slightly higher risk, but as it is, if you have doses to the rectum which are above that red line, your bowel toxicity risk increase. And you can do obviously an EQD2 plot, which is then applicable for either the bowels, the pelvic node patients, or the prostate. Next one, please. So we have looked at this, and these are the risk if you want numbers and bar charts. As you can see, the lower risk patients in the prostate only have a fairly low risk with our treatment protocols. And I haste to say that's an average of 7 consultants. We do not review every prostate patient in a meeting because we really don't have the capacity to do that. But that's what you can achieve with reasonable peer review of outliers, because we all know there are some patients who are difficult and other patients who aren't. And so that's what we have done to keep the workload at an acceptable level for the people who do peer reviews on the one side, and the other side get the best out of the system without overloading it. Next one, please. So in conclusion, all patients were planned with the same class solutions, which we had developed over time from the CHIP class solutions we used at a time when we did CHIP, and then the dose painting plans, and then Pivotal Boost, which exactly uses these class solutions. When we used these constraints, they were very effective, and we managed to realize them for all treatment plans. Overall, we achieved a very low level of bowel toxicity. The National Prostate Cancer Audit data were accurate, and the toxicity reported was reflecting reality, which is an important point. We found that patients with pelvic node radiotherapy and patients with higher rectal doses had a higher risk of gastrointestinal complications. And as I said, it may well be that our slightly different treatment protocols reflected this. Higher rectal doses have a higher toxicity, and what's quite important, but I don't think people quite realize in the moment in some centers, is that the lower doses are also important. And this is particularly important if you use VMAT and or static IMRT, because unless you tell your computer to reduce the lower doses, you will get a rectal bath, which invariably reduces what I call the elasticity of the rectum. So it becomes a stiffer organ, and you get these functional endpoint problems with diarrhea, bowel frequency, reduced storage capacity, and if it's worse, rectal kind of ulcerations, pain, and tenesmus. There was a trend for more bowel toxicity for bowel doses between V20 and V40, but we haven't found a significant level yet, presumably because the rectal doses override this to a certain extent, and we'll have to see how we can combine this in due course. Next one, which is my last. So we will try to use this analysis method we have developed for the prostate versus pelvic node randomization in Pivotal Boost. As you know, that randomization has closed, and we'll see how this analysis method will work for trial patients where all patients were treated according to a same protocol. We haven't got a good explanation yet for the toxicity in the pelvic node group, but it's interesting and needs a bit more work. And the other thing to say, there were 2 small randomized trial, Pivotal, which is UK trial, and also POP-RT from India, and they haven't found these effects. Not quite sure why not, but you know, there were sort of 250 patients, and maybe that's not the number which is adequate to find these type of difference within the statistics. And finally, I want to say a big thank you to Alison, Julia, the National Prostate Cancer Audit Team, Ajay, and my colleagues in Clatterbridge.